Welcome to Quick Medical Review. Today, cellulitis and necrotizing fasciitis in under 5 minutes. Let's go. Buzzwords first. Cellulitis spreading erythema, warmth, tenderness, no defined border. Staph and strep, the most common organisms. Necrotizing fasciitis, pain out of proportion, crepitus, surgical emergency. Gas gangrene, Clostridium perfringens. Fournier gangrene, perineal, necrotizing fasciitis. Let's break it down. Cellulitis, infection of the dermis and subcutaneous tissue, the most common bacterial skin infection. Organisms group A: Strep, Streptococcus pyogenes, and Staph aureus, including MRSA. In special situations, Pasturella from animal bites, Vibrio vulnificus from saltwater exposure, Aeromonas from fresh water. Risk factors: skin breaks, trauma, surgery, ulcers, tinea pedis, the most common entry point, lymphedema, obesity, diabetes, immunosuppression. Presentation: expanding area of erythema, warm, tender, swollen, with poorly defined borders, usually unilateral. Fever and malaise. No fluctuance distinguishes from abscess. Streaking lymphangitis, red streaks tracking toward lymph nodes indicates lymphatic spread. Diagnosis: clinical. Blood cultures are usually negative, imaging only if concerned for deeper infection. Treatment: mild oral antibiotics, cephalexin or dicloxacillin. If MRSA concerned, trimethoprim, sulfamethoxazole, or doxycycline. Moderate to severe intravenous antibiotics, cefazolin or vancomycin. If MRSA risk, elevate the affected limb. Mark the borders to monitor progression. Erysipelas, a superficial form of cellulitis affecting the upper dermis and lymphatics. Well demarcated, raised, bright red borders, unlike cellulitis, which has ill-defined borders. Most commonly on the face or lower extremities. Caused by group A: strep. Treat with penicillin or cephalexin. Skin abscess, a walled-off collection of pus. Fluctuant, tender, erythematous mass. Most commonly Staph aureus, including MRSA. Treatment: incision and drainage, the primary treatment. Pack the wound. Antibiotics only needed for surrounding cellulitis, immunocompromise, or systemic symptoms. Necrotizing fasciitis, a rapidly progressive, life-threatening infection of the fascia and subcutaneous tissue, a surgical emergency. Early diagnosis and intervention are critical. Types: Type 1, polymicrobial, mixed, aerobic and anaerobic organisms, more common often in diabetics and immunocompromised. Type 2, monomicrobial, group A: strep, occurs in young, healthy individuals. Presentation: severe pain out of proportion to physical findings. This is the key early clue. Rapidly spreading erythema, dusky or violaceous skin discoloration, hemorrhagic bullae. Crepitus, gas in the tissues, palpable crackling. Systemic toxicity: high fever, tachycardia, hypotension. The skin may appear deceptively normal early, while the deeper tissues are necrotic. Labs: leukocytosis, elevated CK from muscle involvement. CT may show gas in the soft tissues. Treatment: emergent surgical debridement. The definitive treatment: do not delay for imaging. Broad-spectrum intravenous antibiotics, vancomycin plus piperacillin, tazobactam or carbapenem. Return to operating room every 24 to 48 hours for repeat debridement until all necrotic tissue is removed. ICU level care. Gas gangrene caused by Clostridium perfringens from contaminated wounds. Rapid onset pain, swelling, crepitus, brownish discharge. X-ray shows gas in tissues. Treatment: surgical debridement plus penicillin plus clindamycin. Fournier gangrene, necrotizing fasciitis of the perineum and genitalia, a urologic emergency, more common in diabetic men. Same treatment principles. Example: cellulitis equals spreading erythema without defined borders. Treat with cephalexin or vancomycin for MRSA. Necrotizing fasciitis equals pain out of proportion plus crepitus, surgical emergency, do not delay debridement. Abscess equals incision and drainage, the primary treatment. That was cellulitis and necrotizing fasciitis on Quick Medical Review. Study smart, not hard.